we can label that left, label Sean. Okay, so here you have a little, it's not as smooth. You notice that?
Yes.
Try that again. Hard for you? Okay. Put this in between your finger. So when you look at the evaluation of her handwriting, you can see that there's no major difference in changes in font size or sways when she repeats her sentence, but when she performs Archimedes circles, you can see those breakdowns and movements are not very smooth. The lack of smoothness with Archimedes circles is actually found on both sides, but it's much more evident on the left side. And whenever you see these breakdowns of these smooth lines with Archimedes circles, you're always suspecting tremor. Now, there's three different types of tremor that may cause these. One is the physiological tremor. Physiological tremor happens usually when someone has metabolic issues where their epinephrine, norepinephrine is very too high. Like if someone had 20 cups of coffee, you'll see that with dysautonomias. You can also see physiological tremor when someone is in a hyperthyroid, overactive thyroid state and have too much T3 circulating in their system, increasing their metabolic rate, causing that physiological tremor. The key feature of a physiological tremor is that the rhythms are rapid and equal up and down the same type of amplitude. The other kind of tremor that can cause these Archimedes circles to not have smooth lines is a resting tremor. And resting tremors you'll see with injury to the basic ganglia or basic ganglia disease like Parkinson's disease. And with them you'll see tremor at rest, and then once they stick their hands out, the tremor stops and then it reemerges. So you'll see that right after I noticed she had breakdown of her smooth lines with Archimedes circles, I put her hands out. I want to see what kind of tremor she had. And when you put napkins in between the fingers, it lets you see movement much easier. And we didn't see any signs of physiological tremor, and we didn't see any signs of a resting tremor. So she's really having tremor only with movement. So this is kinetic tremor. And kinetic tremor, meaning tremor only when they're moving, such as writing, is associated with cerebellar injury. So with her history, we know she's had severe motor vehicle accidents, as to the point where, actually biking accidents where she actually has broken her helmet on more than one occasion. So with this immediate handwriting examination finding, we know we're going to have part of her chief complaint be associated with traumatic brain injury. And furthermore, we expect to see other signs of kinetic tremor throughout the exam, which is associated with injury to the cerebellum. So when we look at her blood pressure, we can see that her seated blood pressure is 110/73. And that's within, normal parameters of blood pressure. And then when she stands up, we see her blood pressure is 114/81, which is great, which lets us know she doesn't have any drops of blood pressure, any orthostatic hypotensive events. And then we check her blood pressure simultaneous and bilateral. And the reason I'm doing that is whenever there's traumatic brain injury, there's always the possibility of dysautonomia, and sometimes we see massive differences between one side or the other when this occurs, and you typically also see abnormal pupil responses and pupil dilations and heart rates all over the place. And since we know from her history that she's got major risk for having brain injury as the main cause of her chief complaints, we can just see that her blood pressure differences are there slightly, but within normal parameters. So the left side is 120 over 82, and her right blood pressure was 114/78 when they were taking simultaneously. And you got to account for an error of about 5 points. So systolically, she's had a 6-point difference, which is within that 5-point parameter difference, and diastolically, she had just about a 4-point difference. So it wasn't anything drastic that was clinically significant. Furthermore, when you look at our resting heart rate throughout all these blood pressure measurements, it's somewhere between 60 to 65. With people that have dysautonomia from head injury, you see it go from like 60 to 100, and then down to 70, and then down to 60, and then down to 85, and then up to 100. And we don't see those types of patterns that associate dysautonomia. Now, her SbO2, her tissue saturation of oxygen, was nice and healthy at 99%. Let's check your refill time here. It's delayed.
It is?
Yeah, so here we go. I'll push here. 1, 2, 3, 4. 1, 2, 3, 4. Right on the ball. 1. Okay. Your skin here. Any problem with your skin?
I mean, besides being dry, I didn't
Yeah.
put any lotion on so you could see
Definitely have the dry skin here.
dry skin here. Like, this is a lot different than it used to be.
Just gonna see if you have any blanching. A little bit.
What's that?
See, you can see my thumb.
Mm-hmm.
It's a little blanching. Nothing to worry about. Okay. Yeah, you're very dry. Wow, look at your
I
knuckles.
was like, wow.
So you can see that the capillary refill time is abnormal. It's more than 2 seconds, that 4 seconds in her lower extremity. It just lets us know that her vascular dynamics are not efficient in her lower extremity. We also can see that she's got some slight skin blanching, but it's within normal limits. Some people just, because of their skin color and tone, when they'll have a little bit of blanching, but immediately resolves to normal. It's not anything that's clinically significant. And then when we take a look at her skin, we can see it's extremely dry. Now, extremely dry skin you'll see all the time with people that have hypothyroidism. Thyroid hormones are necessary for efficient metabolic activity of the skin and dermal metabolism, so that's something to consider. But we also see it with people that have essential fatty acid issues. Now, you have to remember, in her medical history, she has some significant gallbladder ejection issues, which means her gallbladder is not really releasing bile. And this can cause essential fatty acid deficiencies. It can also cause deficiencies in fat-soluble vitamins like vitamin A, vitamin E, which are essential to maintain healthy skin and to avoid dryness of the skin. So her expressions of dryness of skin are most likely associated with probably reduced efficiency in absorbing essential fatty acids and vitamin A and vitamin E, because she is consuming a healthy diet that contains those foods, but she has some significant impairments of her gallbladder ejection fractures. So those are the key things to identify from this part of the exam. Other side. Okay. Evaluation of the inner eyelids is just a really quick screen to look for any red flags for anemia. And if you see really pale inner eyelids, you always suspect the person may have anemia. Now, hers are nice and pink and healthy. Not too bad. See your temperature? Backwards.
83 point.
Yeah.
Is that circulation?
Yeah. Mm-hmm. That's pretty good, actually.
Really? It's improved. My feet and hands used to be really cold all the time.
Yeah. The other side. Whenever you're evaluating circulation by comparing temperature differences between proximal and distal tissue with a surface temperature reading, you want to make sure that the difference in temperature is less than 10 degrees. Now we can see with her feet, she has, for sure less than 10 degree difference. Her temperature in her thigh was around 84 to 86 degrees, and then as we went down to her feet, it was down to like 80 degrees temperature, 81.6. So those are pretty healthy. Her upper extremity was about 12 degree difference between her proximal biceps for upper shoulder area down to her fingertips, and that's less, more than 10 degrees, but it's still within normal limits. We don't see any major issues with the circulation from this part of the exam. Okay, take a deep breath in and out. All the way up. Same. One time. Okay. So just keep doing that as I place this on you. A little bit deeper. All the way up. Again. Again. Deep breath. Again. All the way out. Perfect. So in this part of the exam, we're just doing auscultation throughout the body. Start with the carotid arteries. The carotid arteries are normal. We don't hear any bruits during auscultation. Then as we move on to the heart, we can see her heart sounds are normal. There's no indications of any splits, murmurs, or extra heart sounds. There's no significant changes in her heart sounds with changes in respiration. As I listen to her lungs as she takes deep breaths in and out, everything sounds great. There's no wheezing, crackles, rails, ronchi, or anything abnormal. And then as she's breathing in and out, we can see she has normal activity of her respiratory muscles And then with her chest excursion, we can see she has normal amount of chest expansion. So everything with her auscultation to her carotid arteries, heart, lungs are normal. Okay, let's take a look at your thyroid. Just relax your neck here. Just gonna inspect. Head out that way. Hey, go ahead and bring it down. Okay. Go ahead and swallow. Okay. So you can see with inspection of the thyroid gland that there's no clear patterns of any diffuse enlargement or any kind of isolated enlargements on one lobe or the other. Everything looks normal. And then palpation of the thyroid was normal. There's no signs of swelling, there's no pain, there's no nodules that were evident, there's no cartilage tissue enlargement you see with goiter. So a normal thyroid inspection and palpation.
It's the middle pinwheel.
This is your abdominal reflex. You feel your belly button. Perfect. In this part of the exam, I'm doing the abdominal reflex test. I'm stroking the skin around her umbilicus, and you can see that belly button just shift right into the stimuli. And it's normal on both sides. We can see that just stroking the skin around the belly button on the left and on the right causes a normal response. Now, this is important because one of the chief complaints she has is an overactive bladder, and this is sometimes known as a neurogenic bladder. And this abdominal reflex will really evaluate midline muscles associated with the anterior spinal thalamic tract. The anterior spinal thalamic tract is the descending motor projection to the muscles of the bladder. Now, the bladder itself has autonomic fibers and areas in the intermediate lateral cell column that are involved, but this is just making sure that there's no abnormalities in that descending pathways to the midline areas of the trunk and to the bladder tone from a descending motor pathway. Everything is normal. Here. All right. So with the abdominal examination, we can see with general inspection, we don't see any abnormalities of the abdomen. And then as I auscultate the abdomen, we have no abnormal bowel sounds. Her bowel sounds are healthy, strong, normal frequency. And then when I palpate her abdomen, I'm looking for any signs of swelling or inflammation, especially around her liver, anywhere in the abdomen, and everything is there. And then we also percuss to look for any indications of abnormal dullness or sounds that are associated with enlargement. Now remember, she has a history of having parasitic worms. She has helminths, and even recent stool, she's found some worms, and she's getting treatment for those parasitic infections, but sometimes they can cause inflammation and swelling in the livers. It's very possible that her reduced gallbladder ejection fracture testing has shown that they're impaired, and it may be because of these pinworms that can furrow into the gallbladder and common bile duct. Now, in her case, her abdominal exam is normal. If you feel any symptoms. Okay?
Mm-hmm.
The other way. Any symptoms?
No.
Okay. Great. With the declines test, the patient's head is put into rotation, full rotation and extension to put some strain on those vertebral arteries and any types of insufficiency, vertebral basilar artery insufficiency. We can see a person develop nystagmus or get dizziness, and with her we can see on both sides everything's normal. So spirometric testing was conducted, and you can see that she has very good expiration of her lung volume, her forced vital capacity, her forced expiratory volume in 1 second, her percentage of forced vital capacity in 1 second, her forced expiratory time, and her expiratory flow rates at 25.5% were all normal within the parameters of people with her own age, sex, height, and race. So everything is great with her lungs.
Coffee.
Okay, try the other side. Tell me if that smells the same.
A little different, maybe.
What do you notice?
A little bit brighter? I don't know. It smells a little bit more woody on this side and a little bit more citrusy on this side.
Okay.
I don't know.
No.
That's totally
really
different.
Important. That's really important. Smell it?
Mm-hmm.
Try the other side.
It
Same.
smells about the same.
Okay. Okay, tell me if it's the same from one to the other.
Can I go back?
Yeah.
Mostly the same. Maybe if there's any difference, it's like the coffee one, kind of slightly different.
Slightly different.
Maybe.
One side to the other.
Maybe.
You're not. It's normal. I mean, it's not normal, but it's.
I know
it
there's
happens.
less passage on this side.
Let's try again. So there's different citruses on this side, you said, and more smoky on the other side.
Maybe. I think.
Don't doubt yourself if that's what it is. That's what it is.
Yeah, I guess so.
Okay.
There.
Okay. To the other side.
There.
The olfactory examination can tell us a lot about what's happening with the patient's brain. Now, when someone smells something, they have to be able to first have nasal secretions to produce the chemicals that allow us to be able to break down those aromatic rings and fire neuronal pathways through our olfactory nerve. So that's dependent upon the ability to produce nasal secretions through visceromotor pathways through cranial nerve 7, which is in the pontine regions. Now, with her, she can smell both sides, but she has a little bit of dysosmia where she recognizes coffee differently than what it smells like. She recognizes it as a woody smell. And this is sometimes associated with dysfunction of the ipsilateral, same side, olfactory regions of the temporal lobe. So we don't know with her if she has any injury to this regions. Obviously, she has multiple injuries to her brain with her many accidents that she's had. And whenever someone has multiple accidents, you're also worried about having the olfactory nerve pathway severed as the nerves go through the cribriform plate. So her olfactory nerve pathways are intact. She just has a little bit of slight dysosmia on that left side. In by itself is not too significant for anything significant. But if a patient starts to have phantom smells, or they have what's called periosmia, where something that should smell like coffee all of a sudden smells like trash, then we're really worried about injury to her temporal lobe olfactory centers. We also do the peanut butter sniff test, which looks for discrepancy between the perception of the scent of peanut butter between right and left as a tool that can be a risk factor for identifying early Alzheimer's, since Alzheimer's disease has amyloid plaques that start to develop in these temporal regions of the olfactory pathway. But with her, we see everything is normal with peanut butter sniff test. There you go. Can you taste that? What is that?
Salty?
Yep. Okay. How about that?
Maybe sweet?
Yeah. So with gustatory examination, you're looking at the integrity of cranial nerve 7, 9, and 10 that are sending inputs into the solitary nucleus, and then there's projections from that to the thalamus to the orbitofrontal cortex and insular cortex to be able to perceive and recognize those tastes. And with her, everything's intact.
12. 8, 6, 29, 57, 5, 3, 15, 71. 2, 6, 87, 45, 5, 7, 16, 78, or 73.
Tell me, and then compared to the other eye, see if one eye has a greater distinction of color. Contrast. About the same.
I should probably not press. I think they're the same.
The Ishihara charts are used to look for color blindness, and you can see with her she's able to discriminate all the different shades of color, and there's no indication that there's any dysfunction with her visual color discrimination pathways. At the very end of the test, I just have her look at the contrast of color between one eye or the other and see if there's any differences. This is just a quick screen to evaluate the integrity of the occipital lobe. With her history of multiple head injuries and traumas, we want to look for any specific regions of the brain that may be involved. And with people that have injury to their occipital lobe, many times they'll have a reduced level of brightness and sharpness when they close one eye to the other because of the projections that end up on the contralateral occipital lobe regions.
Our eyelashes. Oh. You're going for the eye.
Yeah. So the coronal reflex test is pretty straightforward. You take a tissue, touch the cornea, and see if the patient blinks. The afferent pathway of perceiving the tissue is a trigeminal V1 pathway, and then the contractor of the eyelids themselves is cranial nerve 7 motor aspect of the efferent pathway. And with her, you can see normal coronal reflexes on both sides.
If what?
They feel the same to you?
Yeah. Felt a little lighter on that side. Yeah.
Same. Okay.
There. Right leg. Right foot. Left foot. Right leg. Left leg. Right leg. Left.
Tell me if that feels the same as that.
Feels a little lighter on the right.
Double check sometimes.
It's like a little more pokey on the left.
On the left? Let's double check.
Now it feels the same.
Okay. Do it again.
Yeah.
Okay.
Same. Same.
Screen.
Mm-hmm. Mm-hmm. Same. Same. Yep.
Do you feel that?
Mm-hmm.
Tell me when it stops.
Stop.
Do you feel that?
Yes.
Tell me when it stops.
Stop.
Okay. Now tell me if these feel the same, left or right.
Mm-hmm.
You feel that?
Barely.
Feel that?
Vibrating?
Yeah.
No.
Feel that?
Barely.
Okay. Tell me when it stops.
Stopped.
You feel that?
Mm-hmm.
Tell me when it stops.
Stop.
Tell me that if there's any difference between one side and the other.
Could you do it again?
Let's try.
No, they felt the same.
Different.
Same. 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 Maybe it didn't feel as cold on that one. Same. It doesn't feel so cold on those. Maybe because my hands are cold.
Yeah, it's because of your circulation. We'll go up here. Okay. Now, do you feel the difference between this one and this one?
That's not cold.
Okay. So, whichever one's colder, I want you to say, here's number one, here's number two. Which one's colder?
2.
Here's 1, here's 2.
1.
Okay, keep your eyes closed. Here's 1, here's 2.
2.
Here's 1, here's 2.
1 was colder.
Here's 1,
Mm-hmm.
here's 2.
1.
Here's 1, here's 2.
2.
This is number 1. This is number 2.
1.
Here's number 1. Here's number 2.
1. 2. 2. 2. 1. 2. 2. 2. 1. Now. 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 Now.
Okay.
Now. 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 I feel it, but it's light.
Okay.
Now. 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 A battery?
Okay. Tell me what this is.
Paperclip.
Okay. What's the letter?
Oh. X.
Okay. Open your eyes. I'm going to touch your fingertips. This is number 1.
Mm-hmm.
This is number 2. This is number 3. This is number 4.
Okay.
Okay. Which am I touching on the left?
2.
Right?
2.
Okay. Don't move your hands at all.
Or don't.
Don't move at all. Don't move them. Which one am I
3.
touching on the right? Or left?
3. What do you mean?
Just close your eyes and feel it.
Mm-hmm.
You feel where it is?
Think so?
Do the same thing with the right ankle.
Okay.
Any differences between doing that with one side or the other?
I don't think so.
Okay. Do the same thing with your left knee and right knee.
Okay.
Same?
Yeah.
Do your left hip and right hip.
Okay. What would be different?
You just maybe can't feel where your left hip is or right hip.
Like sitting on the chair?
Yeah.
Oh, I can feel it.
Okay. How about your left wrist compared to your right wrist?
I can feel it.
Same?
Mm-hmm.
In this part of the examination, I'm evaluating the somatosensory system. So if you remember, the somatosensory system is looking at soma, which is muscles, joints, and ligaments, being perceived by the brain, which is the sensory component, somatosensory. Sensory component involves peripheral nerves, large diameter peripheral nerves, and small C fibers. And then these peripheral nerves are going to basically carry information up the spinal cord, hit the thalamus, and cross to the contralateral somatosensory cortex, or in the parietal lobe, and it'll have a homunculus distribution where you have perceptions of the feet in the superior midline regions, and then the leg, and then the face, and then down to the arms. You can always look at a somatosensory homunculus map to look at those, and you want to look for any deficits in any region, in these regions, especially with someone who's got any kind of demyelinative disease like MS, or in this case we're concerned about any trauma or injury to the brain. So you can see me here going through and doing light touch with the tissue, and light touch is going to really evaluate both large 1A diameter and even C fibers. And you can see with her perception of light touch throughout her face and limbs is intact. Then we check pinprick, and pinprick is going to evaluate small C fiber distributions going to the somatosensory cortex, and you can see those are intact. Vibration test is also normal. Those are proprioceptive, large 1A diameter, posterior column, ascending pathways to the somatosensory cortex. Those are great. Temperature is more of a C fiber distribution. Those are normal. And then 2-point discrimination is conducted, and you can see that she's able to discriminate between the different widths of point stimuli, and those are intact. And when you look at the somatosensory cortex, there are different cells for light touch, for vibration, for temperature perception, but it's still in the distribution of the homunculus. So at this point we can see that There's no indication that she's got any kind of peripheral nerve lesions involving her sensory system, and we also know that her somatosensory cortex is intact because she's able to properly perceive these different types of sensations on her skin. Then you can see me do the monofilament test, and with the monofilament test you want to see if that thin monofilament is perceived throughout the feet. That's one of the best ways to identify large 1A diameter neuropathies, and with her she has no problem identifying the monofilaments. And then we get into different areas of the parietal lobe where we look at discrimination of proprioceptive inputs. So you can see I put a battery in one hand and a paperclip in the other hand, looking at her stereognosis pathways. I draw on her hand an X and O. I was looking at graphesthesia. And then we test extinction. So I have her perceive touch on her fingers one at a time, and then I do them both at the same time. And this is a really good way to look at high function discrimination of the parietal lobe when two different fingers are being touched at the exact same time and they have to discriminate. That's the extinction test. And then we just check position sense perception of where her limbs are in relation to her into space, and you can see that she has normal responses there. So all of these tests confirm that her large 1A fibers, her small C fibers, and her peripheral sensory system in regions of ascending pathways, upper spinal cord, through the spinal thalamic pathways, anterior and lateral spinal thalamic pathways, and posterior column pathways, up the cord, and then up into the thalamus, the VPL and VPM region of the thalamus into the somatosensory cortex, are all healthy and intact. Looks pretty even. Okay, I'm going to check your pupil response. Just look straight ahead. With the pupillary light reflex, you shine a light directly in front of their face so that the light hits both pupils with the same angle. Now, what you're looking for is to see if the spot, the area of the eye that is extending, which will become white from the light, is even from one side to the other. And this is just a test to look for strabismus, or looking for any type of misalignment of the eye muscles. And you can see with her that the pupillary reflex is normal, that the spot where the light hits both eyes when the pin light is directly in front of their face is symmetric. And then when we do the pupillary light reflexes here, you can see that there's a normal, direct, and consensual response. Say ah.
Ah.
Say it again.
Ah.
Keep doing that.
Ah.
5 more.
Ah. 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 Ah.
Okay, great. I'm going to do a gag reflex on you on both sides, okay?
Okay.
Perfect. Okay. Open your mouth. Just going to check your saliva protection. Check your gums. Okay. Those are all good. So with the mouth open, I start to evaluate her palate contracture function. And palatine muscle contracture involves cranial nerves 9 and 10, which are so critical for digestion and motility and swallowing and the brain-gut axis. So when we have her say ah, we can see that her palatine muscles contract. And then I do repeat testing. And repeat testing is a good way to find impaired mitochondrial function or any kind of weakness in these regions of the brain involving the vagus. So when we have her say ah, we have her repeat it and repeat it and repeat it just to stress out the mitochondrial neuronal pools in those vagus pathways, and she's fine. She's able to do repeat palate contracture, and every time she does it, the palate moves correctly, and it doesn't fatigue, and it doesn't stop moving, which is great. And then the gag reflex is intact and normal, nice, sharp, brisk gag reflex. And then evaluation of her mouth, looking at her dental health, looking at her gums, look great, and she has healthy amounts of saliva production. So all of this is letting us know that her parasympathetic activity that is involved with the brain-gut axis is nice and healthy. So I'm using a panoptic ophthalmoscope to do a really good endoscopy of the structures of her eye. And we can see a nice and healthy red reflex, nice and healthy optic disc, nice retinal arteries and veins, and her macula and her retina look very healthy. Nice. The other side. Sinuses are nice and healthy. No congestion.
Oh, yeah.
Not tender at all?
No.
Okay. Here. So examination of her sinus indicate that illumination of her frontal maxillary sinus are normal. You can see that nice red glow when we shine the light into those sinus regions, and then she has no tenderness or pain upon palpation over her sinuses. You got a coated tongue. Can you see that? It's like white. It's like a coated tongue. Even like really back there.
Yeah.
Okay. So when you look at her tongue, you can see two things. First, her tongue is coated. It's coated white. And this typically occurs when people have different dysbiotic conditions of their gut and they get some fungal overgrowths and abnormal bacterial growth. And you'll see this white coating of the tongue. So we know she's dealing with some gastrointestinal issues with her parasitic infections. The second thing you can see here is that she's got a fissured tongue. And the fissured tongue is associated with B vitamin deficiencies, iron deficiencies, but any significant micronutrient deficiency has a potential to cause a fissured tongue. It's not specific for any nutrient, just an idea that there is a potential for some micronutrient deficiencies when that occurs. Now, she has visual confirmation of having parasitic worms, and we have to consider that this may be a possible reason why she's developing potential micronutrient deficiencies and why she has this white coated tongue. Let's see your tone. Okay, check out your reflexes. Let me have your arm here. Evaluation of muscle tone passively while the patient's relaxed is just a really good way to do a general screen for the motor system. So with her, you can see she has normal tone. She has no signs of rigidity. You can have different types of rigidity, like knife clasp rigidity or lead pipe rigidity when there's basal ganglia disease or injury to the basal ganglia. She doesn't have any spasticity or extreme tightness, which you can see with cortical spinal lesions if the frontal lobe or motor areas are injured. And she has no signs of hypotonia, where her legs be very jelly-like and have really no tone, which you see with any kind of cerebellar injury. Now, with her, we really want to evaluate these systems very carefully since she has had so many impacts to her head. Now, if you look at her deep tendon reflexes, they look great. Her upper and lower deep tendon reflexes are nice and brisk, nice and clean. They respond very quickly. They're symmetrical from one side to the other. And then when I tap her hypothenar muscles, we don't see any abnormal movements or percussion myotonia. And then her jaw reflex is nice and brisk as well. So her muscle stretch reflexes and tone are nice and healthy. Stroke here. Stroke your cheek. I'm gonna keep your hands here. Stroke your foot. Hopefully not too ticklish. Squeeze your calf. I'm going to quickly stretch your foot.
Okay.
Just relax. Okay. In this part of the exam, we're looking for upper motor neuron signs. And upper motor neuron signs indicate any kind of lesion to descending cortical spinal pathways all the way up to the anterior horn. And here we start with just doing very basic primitive reflexes of palmar stroking. A palmar stroking is basically a primitive reflex of the grasp reflex. You stroke the palm, you should see nothing happen. If a person goes into a grasp reflex, you suspect some type of upper motor neuron injury. And then you can see me stroking her cheeks. I'm doing the rooting reflex, and we should see nothing happen when we do that. If you see the lips moving into like a sucking fashion, that would be signs of an upper motor neuron lesion. Then you'll see me flick her fingers, and as I flick her fingers, we're doing a quick stretch on those flexor muscles and seeing if her thumb and first digit come together. We're looking for what's called a Trommer sign, and she does not have an abnormal pattern there. And then I stroke the bottom of her feet to see if she's in a toe flaring, toe extension, or the Babinski sign as indication of any upper motor neuron lesions, and those are intact as well. And then lastly, do a quick stretch of her muscles to see if we see any kind of clonus activity, these rhythmic types of muscle contractions that occur after a quick stretch, and she does not have that. So there's no indication of any type of upper motor neuron lesion. Try to time them together.
At the same time.
Yeah. Can you go faster?
Than this?
Yeah.
Whoa, no, I can't do that.
Is it getting harder?
I think so.
Which side? Do you feel it?
Being tired?
Yeah.
The left side.
Yeah. Okay, put your hands like this.
Yeah, I definitely feel it.
You feel it? Play the piano as fast as you can. Keep going. Faster. Feel it? Difference?
I just can't go as fast.
Do you feel tired, fatigue on one side?
Yeah, this side.
This side?
Mm-hmm.
Are you left or right-handed?
I'm right-handed, yeah.
Okay. All right.
Mm-hmm.
Now, what I want you to do this. Yeah, just do the right side first. Finger to finger each. Yeah, finger to thumb. Yeah, perfect. As fast as you can. Just one at a time. Go hard.
Yeah, I'm trying to do two.
Yeah. One at a time.
Fine. I can do it like that.
Yeah.
Whoop.
This is called dyspraxia. You have a hard time with this. It's the motor cortex. Do the other side.
Maybe this is the stairs.
Oops. Yeah. It's dyspraxia. Let's make it a little harder for you. Let's have you put your hands up. You're going to do this finger, and this finger, then this finger.
1, 2, 3, 4.
Yeah. With your thumb, though.
Oh.
Yep, you did it. Oops. Okay. Do the other side. Same pattern. Faster. Yeah. Okay, try to do them together.
So
Faster. Fast as you can. You can keep your hands with palms open.
Oh, okay.
But at the same time. Try to, instead of doing like, same time. There you go, fast again. Yeah, it's really slow. See, this is the dyspraxia again. Try to time them together.
Yeah.
Can you do it? So the thumbs coming at the same time, pinky's coming at the same time. No?
I mean, this is good.
That's the best you can do. Keep going. Yeah.
Seems safe.
Start again, take a break.
Yeah.
So you're gonna bring it out? At the same time you're gonna go is that the fast you can go? Go a little faster. Yeah. And then left foot. Together.
At the same time. Okay.
Same time. Take a break. Oh. You can hear it. Same time. You're going.
I'm trying.
Okay. Not
Do you want me to
this.
slow down until it's...
No, once you go fast you can. Yeah. Okay. Fast you can.
Oh.
Faster.
Mm-hmm.
These are all motor strip.
Yeah.
Other side. Okay, close your eyes. Same thing. Perfect. Okay. Okay, with rapid motor testing, we're evaluating different regions of the brain. So first of all, the ability to coordinate the sequence of activities and which movements come first and in what order, that volitional thought process. That's all generated by the pre-motor area of the cortex on the contralateral side of the limb. And then the amplitude and the speed of how the movement is done is generated by the motor strip on the contralateral side. And then when you look at the smoothness of activity, just the smooth movements, being able to turn muscles on and off, that's done by the cerebellum. And then the basal ganglia make sure that it's also moving rapidly enough through the direct pathway, and the indirect pathway is there to just suppress any unwanted movements. Motor testing, as we go finger to thumb, finger to thumb, finger to thumb, we can see that there's some differences between the left and right side right off the bat. And then as we further investigate her rapid motor movements with specific finger to thumb, finger to thumb, finger to thumb, we can see she's having some difficulty with that movement. It's on both sides, but you can see greater significant loss on the left. We can also see that her movements are not as smooth, and she has larger gross movements on that left side. And these all indicate the potential for some degree of injury with her past medical history of trauma to her brain, to potentially the premotor strips more expressed on the right side, since we're seeing the expressions on the left side. And then when she goes in through supination, pronation, back and forth rapidly, there's a little bit of inefficiency on that left side involving those motor coordinations. And then with rapid foot tapping, you can even hear the dysrhythmia that takes place. So we can see some involvement of potential inefficiency in those motor regions. And these may be attributed to some of the injuries that she has had, specifically breaking her helmet, and most of the impact was done on the front side, impacting those specific regions. Okay, a couple times. There you go. Perfect. Pull out your cheeks. Okay, close your eyes tight. Great. Relax. Push your tongue against your cheek. I'm going to push against it.
Mm-hmm.
Other side. Okay, open and close your jaw. Whoa. You got a little bit of deviation and click there. Yeah. Is that new?
I don't think so.
Okay. So the motor pathways of the brainstem, the cortical bulbar pathways, are tested here. You can see that when we have her contract her facial muscles, we see symmetric muscle movements on both sides. So we know that those cranial nerve 7 motor pathways are intact. Then I have her push her tongue against her cheek and check the degree of resistance against her tongue to evaluate the hypoglossal motor branches. And then I have her open and close her jaw to look at that trigeminal motor function. Now, she can't open and close her jaw. She has some deviations. There could be some type of dysfunction in those TMJ articulate structures, even probably from her falls or trauma. At this point, it's not clear. But there's definitely motor activity in those trigeminal pathways. The muscles are contracting. It's just some dysfunction that's occurring when she opens and closes her jaw, involving that smooth movement, which could be either neurological or joint, but at this point it seems to be more of a joint manifestation, since she doesn't have other significant signs of cortical bulbar pathway dysfunction or indications of things like cerebellar disease or spasticity or changes of tone in those jaw muscles, which should be more of a central origin cause of TMJ movement dysfunction.
Okay.
Don't blink. Perfect. Okay. With glabellar tapping, you basically take your finger and tap between the eyes right over the glabella. And a normal response is to have a person maybe blink for the first two and then stop blinking altogether. People that have Parkinson's disease or some kind of disease, dysfunction, or injury to the basic ganglia, what you'll see is that after multiple taps, they really have to keep blinking and blinking and blinking. So that is called a Myerson sign, and we can see she does not have that. Now, the startle reflex is just quickly bringing something into her visual field and seeing if she has any kind of abnormal jerking or movement, and with her, everything is intact. The cover-uncover test is used to identify any hidden sources of eye muscle weaknesses. And eye muscles are a reflection of cranial nerve 3, 4, and 6 function, motor function. So when we do a cover and then uncover, we're removing the visual fields that the eyes would normally have conjugate balance of eye position, and when you cover one eye, you can see compensations be removed. Now, with her, we don't see any type of cover or uncover exophoria, esophoria, and this is in line with the fact when we did the pupillary light reflection, shine the light directly in her visual frontal areas of visual field, the light hit her eyes directly. This lets us know that her muscles are aligned, there's no hidden compensatory mechanisms, and in cranial nerves 3, 4, and 6 are intact in that brainstem region. Just use your eyes. Visual tracking evaluates integrity of different brainstem and cortical regions. So in the brainstem, we have 3, 4, and 6, and different visual tracking centers involving different cells within the anterior brainstem. And then we have the frontal eye field and the cortex. Now, as we have her move to different directions or visual fields, to the right, to the left, up, down, diagonally, in both up or downward directions, we can see that she's following the target very, very well. Now, any jerkiness, any kind of nystagmus, any kind of double vision lets us know that there's something wrong with those integration centers, or sometimes there's even something wrong with the eye itself. Some people may have hyperthyroidism and have their eye muscles enlarged, and there's a slight protrusion, and they'll start to see double vision when they start to go into different gazes. Sometimes people with demyelinative diseases like MS or autoimmunity, when they start to look in different gazes, they may have some abnormal eye movements where the eyes just jerk. They could have what are called jerky movements, or they could have nystagmus movements like that rhythmic, slow and fast-paced movement. And with her, we can see that our visual eye tracking system is working great. This way. Okay. High burst, rapid targeting of the eyes is called saccades. The speed of saccades is associated with the frontal eye field, and the ability to stop saccades at a target without overshooting, undershooting involves the cerebellum. And with her, we can see that her saccades are intact. The optokinetic reflex is tested by using a red and white strip, moving horizontally or vertically, or even diagonally, different directions. What you're looking for is smooth pursuit movements to the side of where you're moving the tape, and then a quick jerk back for the next red line that they notice in their visual field. And optokinetic activity in general can lead to dizziness and vertigo and anxiety and high heart rate with people that have like cerebellar disease, cerebellar injury, like gluten ataxia individuals, or people that have had some kind of injury to their cerebellum, or even Hashimoto's patients that have cross reactivity with TPO to those regions. So that's not common to see. And you can also have some people that have vestibular system integrity after you do the stimulation, feel like they are moving or spinning to one side, or they get dizzy. Now with her, we can see that her optokinetic eye movements itself, those slow and fast movements, are symmetrical, right to left, up and down, and that they're intact, and there's no fatigue or any symptoms induced with this optokinetic reflex. The vestibular-ocular reflex is tested by holding the patient's head and having them relax their eyes as you move their head in different positions. Now, if the vestibular-ocular reflex is working properly, when you move their head to the right, their eyes should go to the left. When you move their head up, the eyes should go down. When you move their head down, their eyes should go up. And this is a normal reflex that involves the cerebellum and different brainstem regions. Now, with her, you can see everything is working perfectly. You also will see me do these head impulse tests, and the head impulse test is a way just to look at integrity of that midline cerebellar called the vestibulocerebellum. And as you quickly thrust the head from one side straight to the center, you're looking to see if the eyes have any bouncing or any kind of abnormal movements, which would indicate that there's some kind of injury or dysfunction or degeneration to that midline vestibulocerebellum region. And with her, we can see that everything's intact. Oops. There we go. Any dizziness?
No.
Come on. With the Dix-Hallpike maneuver, I like to have a patient wear Frenzel goggles, and these Frenzel goggles allow you as a practitioner to see their pupils, but it's hazy enough where the patient can't fixate on a target, and visual fixation on a target will suppress nystagmus. The purpose of the Dix-Hallpike maneuver is to put a patient in a position to evoke movement of the receptors of the posterior canal to activate, and in a normal response, you shouldn't see any abnormal eye movements. However, if there's crystals dislodged into that canal system, you get an overactive response in that position, and the person can feel dizzy, and you're going to see abnormal eye movements called nystagmus. Now, with her, we can see when we test her in both left and right posterior canal positions, she has no abnormal findings. Keep doing that a few times. Just one more time.
Every other.
A, C.
A, C, E, G, I, K, M, O, Q.
Okay, start with B, go back.
B, D, F.
Okay, and walk normal. Without, just walk normal. When evaluating ambulation, you should always look for a few things. You should always look for arm swing, leg swing, any sways to one side, any angulations while they're walking, and any type of compensations when they're walking. For example, a head turn to one side, or having to shift their body back in one position as they ambulate. And with her, you can see that she has, fairly normal gait, normal swings of her arms and legs, no significant sways. And then when she double tasks, she has a little bit of slowness. But outside of that, we don't see any significant clinical impairments with her gait analysis, and even gait analysis with double tasking. Stay right there. Go ahead and close your eyes.
Okay.
Good. You feel okay with that?
Mm-hmm.
Okay. Go ahead and put one foot in front of the other. Eyes open. What's your eyes open?
Okay.
Yeah. Get stable, and then close your eyes when you're stable. Okay, good. Put your feet back. Let's do that side one more time. Bring your left foot forward. Get stable.
Oh, my eyes are closed. They should be
Eyes
open.
open.
Okay.
Okay, when you're stable, as you can be, close your eyes. Okay. Okay, bring your feet back. You feel yourself going to the left?
Yeah.
Yeah.
Mm-hmm.
Now, if you stand here, close your eyes. Do you feel like you're going to the left?
No.
Okay, bring your other foot forward. Try not to touch your feet together.
Oh, okay.
There you go. Close your eyes when you're stable.
Oh, they were closed.
Okay, perfect. I can't see, so. Yeah, you're going left. Yep. Okay. Feet together. Stand on your right foot.
That?
Yeah. And then stand on your left foot.
My eyes are open.
That's perfect.
Okay.
Okay, do that one more time. Now, this time, eyes closed for each one. Okay. Harder on that side. So you're like, looks like you're leaning to the left, that's harder on the left.
Mm-hmm.
Okay. Eyes open.
Like this.
Mhm. Perfect. Come on back to where you started. Do the same thing, eyes closed.
Ooh.
You still, you're going left. You're going left, yeah. Okay, stop.
Tests for stability to let us know a lot about what's happening with the patient. Now, when someone is trying to stay stable, the first thing we have to note is that there's proprioceptive input coming in from the nerves in the lower extremity. And these large 1A diameter fibers are very susceptible to inflammatory responses, and they're also a common area of injury for those that have inflammatory autoimmunity conditions that are like idiopathic neuropathies, large diameter autoimmune neuropathies, and even things like polyneuropathy that takes place with diabetes. Now with her, we know that her 1A large diameter fibers are intact. We checked her vibration sense. We had the monofilament test. We know there's no proprioceptive impairment. And then when we look at her general ability to stay stable, we can see she doesn't have any significant loss. She has some mild sway to the left, which is some inefficiency in that system. And that inefficiency in that system may be just associated with some of the issues we saw with dyspraxia on that left side. So muscle activity and motor tone really works with cerebellar integration to really create this loop. So there could be some degree of involvement, but it doesn't seem to be very significant. Now, when she stands on her feet one by one, you can see she's less stable on the left. When she is standing in a Romberg's position or a tandem Romberg's position with one foot over the other, you can see she's going to the left, but then she overshoots to the right, so it gives the appearance that she may be going to the right, but in fact she's losing sway to the left. And then when she goes heel-toe, she has some sways to the left, and with her eyes closed, she has a little bit of mild ataxia. Nothing that is really significant for us to be very concerned about.
Fast you can. Fast you can. You can open up your hands if you want.
That's distracting, Justin. He's doing it too.
Wait, elbows in, same thing.
Like
this.
Oh.
Hard to do? Okay, same timing. Fast you can. That's the dyspraxia.
That's great.
Okay.
No adjusting it, right? Just leave it where it was. There.
Yep. Do you feel your little tremor right before you touch your nose?
Ooh, what is that?
Close your eyes.
Yeah.
Feel that?
I don't.
Okay. Nose, finger. Go up at that speed. That's perfect. Other side. Other side. Do you feel it?
I guess so.
So this is, let me explain. So this is normal. Go to target.
Mm-hmm.
You're doing this.
Yeah. Okay. Wow.
That's a to-be termination tremor. Normal.
I remember hearing about this, but
That's
I
your
don't
nose?
remember what it meant.
It's cerebellum. There you go. Other side.
Like finger high five.
There it is.
High five. Ah, at that time I did.
Yeah.
I do see it now.
With repeated supination pronation, we can see that the movements are smooth in relation to cerebellar function of turning muscles off and on. We don't see any patterns of dystiotocokinesia, but we do see she's having trouble coordinating the timing of her supination pronation with her left hand compared to the right hand. This is really more of a dyspraxia, motor planning, motor coordination issue that we identified earlier when she was doing isolated finger to thumb, and that's associated with a contralateral or right premotor area, which may be an area of the brain that was injured with her past history. And then as we do finger to nose testing, you can see she's got a little bit of termination tremor at anywhere between 1 to 4 beats of movement, typically 1 and 2 beats of movement right before she gets to the target. And it's found in both the right and left hand, but mostly on the left. Now, if you remember from evaluation of her handwriting, she had some changes in her Archimedes circle that were expressive of a tremor, and those were really associated with kinetic tremor. It was on both sides, but it was much worse on the left. We're seeing the same indication of what we saw with her handwriting evaluations with her finger to nose targeting. It's healed for sure. Yeah, you have a scarred entry eardrum. It's not moving. Yeah, see, look.
And is that like sub?
So if it hits the box, you're normal.
Okay.
Doesn't it?
So with otoscopy, one of the things that I noticed in the right ear is that there was some scarring on that eardrum. And scarring can happen after an ear infection or any kind of injury to the tympanic membrane, let's say from a change in pressure, whether it's impact or a change in pressure in a motor vehicle with the windows down. But any of those things can injure the eardrum and then lead to some scarring. Now, as I did pneumoscopy where I puffed some air into the eardrum, I could clearly see that there was some lack of movement in that right eardrum compared to left. And this was confirmed with tympanometry, where we were able to actually see decreased mobility of that eardrum on that right side. Now, there's no signs of active infection now. It's just an indication that there was some past injury there. And then with the audiometric exam, we didn't see that the scarring of the eardrum had really any loss of sound perception at all the different decibels and frequencies with the hearing test.
Look over here. We're going to just check your pupils in darkness and light. They dilate. Perfect. And they constrict. Perfect. Okay. And then I'm going to close one of these eyes on you here. Okay. Okay. I'm going to open the right. It's a direct consensual response. Very good. Open up the left.
With the infrared cameras on, we can really look at the pupils much better. And first thing you'll notice is there's a difference in pupil size. That's normal. No one's going to have perfectly symmetrical pupils. What you're really interested in is if there is a normal contraction that's symmetrical to both sides. The degree of contraction should be the same, even though one pupil may be slightly different in size than the other one. So it's really the motor response that you're concerned about. Just like everyone has asymmetrical body parts, right? Not everyone's ear is symmetrical. Not everyone's left side of the nose is symmetrical with the right side of the nose, and so on. And same with pupils. So here we can see that her pupils respond properly in dark and light, that they dilate in darkness, they constrict when the light's turned on, And then as we do direct and consensual again, by opening up the left flap and then the right flap, we can see normal pupil responses. Perfect. Do that one more time. And we see convergence and accommodation. Perfect. So while the patient is wearing these VNG goggles, we can really take a good look at her pupils, and we're having her stare at her thumb as she brings her thumb towards her nose, and that visual convergence and accommodation, that pupil response that constricts is taking place. We have normal visual convergence and accommodation. I'm going to close these on you so you can't see. I want you to look to the right. Okay. Stop. Does that make you tired?
I don't think so.
I'll show you. So you just your eyes do that. Look to the right. You see that? Bouncing. That's like holding weight and doing that. That's the frontal eye field. So you see fatigue right there. Look to the opposite side. See that bounce? That's like holding weight here. You can't do it. It's the frontal eye field. It's right next to the motor strip. Okay. Does that make you tired?
Not really.
Good. Look all the way up. See? That's not nystagmus, it's just fatigue. Go look down. So visual gaze can give us a clue about what's happening with different areas of the brain and different eye muscles. So when we have a look to the left, we're activating the right frontal eye field and the left lateral rectus and the right medial rectus. And one of the things we notice with her is that when she looks to one side, you can see that fatigue of her eye muscles, almost as if you were asked to hold a really heavy book above your head and your arms just dropped a little bit and then dropped a little bit and dropped a little bit, and the book was heavy so your arms dropped and then you pushed it back up, and then the book was heavy so your hands dropped and you pushed it back up. And that's what we're seeing with her gaze. We're seeing it to both sides and we're seeing it up. So this is letting us know that the integrity of her frontal eye fields are compromised. She doesn't really have the amplitude or the endurance. So the degree of mitochondria there that would be able to maintain sustained gaze or sustained activation of those neural pools is really inefficient. So this correlates with all the other things we're seeing with the examination. With some of her dyspraxia, we see on both sides, but it was obviously worse on the left. And here we're seeing all fields of gaze issues where she's having fatigue. Now, it's not nystagmus. With nystagmus, you would have a very clear slow and fast phase that would indicate other types of pathologies. This is just the eye muscle fatiguing and then letting go and then catching up again and letting go. There isn't a slow and fast phase, and that's why it's not nystagmus and just general fatigue of those directions of gaze. Just relax. I'm going to move your head to the left. Move your head to the right. Okay, I'm going to open these up. I'm going to rotate you in the chair.
Okay.
Back and forth. Check your vestibulo-ocular reflexes. Does that give you any symptoms or any problems?
Mm-mm.
So those are normal reflexes. They should stop by having you stare at your thumb. Go ahead and stare at your thumb. Keep your eye right on that. Okay, so visual fixation cancels out the vestibulo-ocular reflexes. That's good. Can you get this to jump? Perfect. So rotations of the head activate vestibulo-ocular reflexes. So when we have a rotated head to the left and to the right, we can see a normal vestibulo-ocular reflex. And this is basically nystagmus type movements. So when a person moves their head to the right, you'll see the eyes go into a slow phase in the opposite direction, then a fast phase in the direction that they're spinning or their head is moving. And you can see with hers, reflexes, they're intact and they're symmetrical between right and left. They don't deviate up, they don't deviate down, they don't pause, they don't stop. So she has a normal vestibulo-ocular reflex. Then we add stimulus to it by rotating in the chair that increases the severity of inputs coming into the intensity, I should say, of the inputs coming into the vestibular system with chair rotations, and then we don't see any symptoms of dizziness or any abnormalities in these eye movements. They're nice and symmetrical with both sides. And then we have her stare at her thumb, and when someone stares at the thumb, even though you're moving them back and forth, let's say in this case a chair rotation, there's no more vestibulo-ocular reflex. If the areas in the frontal lobe are working well with basic ganglia, they can dampen these vestibular ocular reflexes that are generated by the vestibular apparatus in the midline cerebellum. So she looks like her midline cerebellum and her vestibular reflexes are all nice and healthy. 3, 4, 5, 6, 7, 8, 9, 10. You have any dizziness at all?
No.
3, 4, 5, 6, 7, 8, 9, 10. Okay. I'm going to clap next to your ear.
Okay.
Just going to compress your ear. Go ahead and hyperventilate for 10 seconds. 6, 7, 8, 9, 10. Just relax your eyes. The head shake test is a really effective way to provoke nystagmus with anyone that has some subtle abnormalities. So the head shake test can be done in rotation, where you have a person shake their head to the left and right, or it can be done in flexion extension. And what you want to see is someone do the head shake test and have, when they stop, have no nystagmus or abnormal eye movements present. And with her, you can see that she had a normal response. She did head rotation back and forth to the right and left, didn't notice any dizziness or any kind of lightheadedness or any symptoms when she stopped shaking her head. There was no abnormal eye movements or nystagmus that presented itself. And the same thing with flexion extension. She rotated or flexed and extended her head repeatedly, and then activates more of the anterior and posterior canals in comparison to the horizontal vestibular canals. And here we can see that there's no abnormal eye movements or any kind of symptoms that were developed with repeated flexion extension. This lets us know that her vestibular system is intact.